Welcome to AI for Good, the leading action-oriented global and inclusive United Nations platform on AI. Organized by ITU in partnership with 40 UN sister organizations and co-convened with Switzerland. The goal of AI for Good is to identify practical applications of AI to advance the United Nations Sustainable Development Goals and scale those solutions for global impact. In today's session, we're counting on you to use the live video wall feature to ask questions and post comments to help create an engaging discussion. We encourage you to stay until the end, as we will hold a 30-minute networking session in the neural network. Here you can meet, ask questions to our distinguished speakers, connect, and chat with the AI for Good community. It is now time to kick off the session and welcome our first speaker. The floor is yours.
Hello, everyone. Good morning, good afternoon, good evening. My name is Matthias Gröschel, and I welcome you to today's AI for Good webinar by John Brownstein. It has a wonderful title, Digital and the Future of Disease Surveillance, very timely. And as you all know, these webinars are co-hosted by Harvard Medical School's Department of Biomedical Informatics. And a couple of times a year, I sit down with the chair, Zach Kohani, and we go through names and of potential speakers, and John's name came up very early and at the top. So I'm really honored that we have John here today with us. So John Brownstein is a professor at Harvard Medical School and the Chief Innovation Officer at Boston Children's Hospital, and has been at Boston Children's for more than 11 years. John is a global leader in the emerging fields of informatics and big data analytics, and runs a 50-person multidisciplinary team focused on digital innovations that span from clinicians, nurses to consumers. His research group and team is supported by several multi-million-dollar grants from the National Institutes of Health, USAID, AID, the CDC, and also Google, Skull, and the Gates Foundation. His work has pioneered the topic of digital epidemiology, where he's utilizing diverse digital data sources to understand and inform population health. He has published over 150 peer-reviewed papers in all kinds of journals, and his work was also recognized by the White House with the Presidential Early Career Award for Scientists and Engineers. So welcome, John. Thanks for being here with us.
Great. Thanks so much for having me. It's really an honor and pleasure to be here and to talk to you a little bit about efforts in public health surveillance and how we're bringing in new technologies, data mining, a little bit of AI, machine learning into play, both to support response to this current pandemic, but how we build tools that are sustainable for future events. So I'm going to share my screen, and we're going to run through some of our efforts over the last couple of years. All right. Yes. Okay. Perfect. So, yeah. So as Matthias said, I'm going to talk about this emerging field of digital epidemiology. And while it's been around, I think now for close to 2 decades, clearly the focus of epidemiology, but also tools and data to support response to pandemics really has become mainstream over the last couple of years, both from actual epidemiologists, but I would say many from the sidelines who've come in to support response and to think about how to bring new emerging tools to the field, which generally has been underfunded. And so public health has been very slow to adopt these kinds of methods compared to other fields. So if we take a little bit of a step back to 2019, December 30th, there was a Chinese language news article talking about a mysterious illness, pneumonia in Wuhan, that impacted 7 patients. And this was an alert for some, a usual article for others. But of course, as we know, that was the first identification of a cluster that ultimately became the COVID-19 pandemic. And the challenge of both identifying that event through mining of news and other sources, but also collating that data to be able to track a virus in real time as it circumnavigated the globe is one that, generally speaking, public health was not necessarily prepared for. Maybe that's, for some listening, this is a major understatement. But what we strove to undertake is to develop technologies, databases, support that allowed us to both identify the events early, characterize this disease, track it, understand the impact of interventions, and develop tools to help mitigate the impact. And so that's what I'll talk about today. And really, the challenge of doing this in the existing healthcare landscape. As many know, the challenge of being able to do population-based surveillance and research is really challenging. We're dealt with very siloed data systems about individuals, very difficult to get a view of a single patient, let alone the view of a full population. And if you want to do deep investigations of clusters, or if you want to understand risk factors of a particular infection, if you want to understand population trends, our current health systems are not geared to fully understand what is happening in populations. And we can take lessons from other fields that have figured this out, and I'm sure many here are in the space of climate. In other areas, including climate, you can tap into large data sets globally that are available in real time, available via APIs to create and fuel an ecosystem of applications and forecasting tools to fully understand what is the existing temperature and forecast of temperature in your particular location. When we think about public health, the challenge has always been the fact that we are missing the underlying data sets. We have no APIs. We have no ecosystem of applications that are geared either towards decision makers, public health officials, or even the general public to fully understand what is going on in real time. We have no disease weather map. We have no disease forecast. And of course, if you think about COVID and whatever else is coming next, to be able to arm people with better data, of course, means ultimately that we can make better decisions at the population level or at the individual level. So if we think about public health and how disease reporting takes place, if you think about even the events of COVID, there's a cluster of illness. Eventually, there's some lab confirmation that ends up in a Ministry of Health. Eventually, that ends up at the WHO to make some decision about whether this represents an important global public health event. Each one of these steps can take days, weeks, even sometimes months before we even have any recognition of what's happening. And that flow of information happens in one direction, meaning that not everyone has access to the same information at the same time, and some stakeholders never have full insight into what's taking place. So when we think about digital epidemiology and the tools in which we're focused on, it's all about sort of disrupting that flow of information to make information available to everyone ultimately at once, to not create this one directional flow of information, and to tap into data that doesn't require some of the same restrictions as data generally we think about in public health, which is sort of detailed case information, electronic medical record data that ultimately gets siloed and is very difficult to both collect, harmonize, and share. So what we turned to many years ago, this was well before COVID, was this concept of the digital exhaust. And again, it's not, if you look at other industries, this is not so disruptive. But when you think about public health, the idea that you can leverage individuals' breadcrumbs, their Google searches, their Facebook likes, their tweets, their wearables, that information generally is not something public health taps into. And we've worked on this for many years to think about what are the health behaviors and outcomes that people leave behind through their sort of digital breadcrumbs, whether that's talking about symptoms of flu, or discussing food poisoning, or it could be drug abuse. There's many public health verticals that could be serviced by understanding both outcomes that people don't necessarily report to their physicians, or behaviors that they would not talk about. And so there's all this meaningful health data amid all this really complicated noise that if we start to tap into, we can actually get insights at the population level, and then ultimately can identify signals earlier in populations and earlier compared to traditional public health monitoring. And not only that, we can get understanding of disease at very large scales, much larger than what we're accustomed to in public health, which is hyperlocal, because it requires deep, intensive data collection at the individual level. So that's been the effort that we've been undertaking now over getting close to 20 years. Our sort of flagship product was a tool called Health Map that was originally funded by Google, with this idea that we could tap into hundreds of thousands of sources across many languages to actually identify particular clues about disease events happening in populations. And the idea is that through web scraping, natural language processing, data mining, machine learning tools, we could take the vast amount of information that's appearing online, filter it, structure it, and make it available to public health agencies. So we're using NLP across, locations, species, disease patterns, case counts. All that is taken to essentially take the massive amount of unstructured data that exists online and turn that into data that can be used from a public health response perspective. So say you have a typhoid outbreak in some part of India that's talked about either on a tweet or a news article. We can take that text, structure it, and then start to filter that information and essentially make that data available. And that's what Health Map has all been about. And in fact, that's what Health Map was focused on as we identified the first clues about COVID at the end of December in 2019. And that was one of the first tools that we brought into play as part of the COVID response. But ultimately, we have a number of tools that we've been developing that all leverage to a certain degree digital sources, data mining, that either focus on early alerting, they focus on verification or characterization of the initial events, which I'll talk about. They allow for surveillance, so monitoring of disease in populations and understanding the impact of different interventions. And then the technologies we're building to actually respond to the pandemic. So I'll give you some examples in each one of these categories as focus areas that our team here in Boston has been working on now for 2.5 years. The first is probably the most controversial project that we worked on. And this was at a time where looking at what was taking place early in China was probably less favorable at a time when the politics were quite heated. But nonetheless, we had this idea of taking from historical work that we had done to look at satellite images of parking lots of hospitals we had initially done this in Latin America, where we could actually predict flu seasons just by how busy hospitals were. We'd also done other work to look at search query data from Baidu to actually predict flu seasons in China. So both of those data sources had been ones that we'd validated previously. And we thought to ourselves, well, what if we started looking at some of this particular information in Wuhan at the time? And so we collected as much imagery, satellite imagery of hospital parking lots in Wuhan as we could possibly identify. It was very challenging because a lot of cloud cover and challenges in terms of image availability. But we started counting the cars in parking lots through the late fall of 2019 to fully understand what was taking place at the time. And the data was incredibly messy. So we're not going to say this was any slam dunk by any means. But what we did see was an increased busyness of the hospitals in Wuhan in late fall, and of course, a flow down as a result of the lockdowns that were taking place. We also saw increases in particular symptoms in late fall as well. Now, of course, this is not validation. These are indirect measures, and there's been a lot of work done since, and we still don't fully know the origin story in terms of the cases and when they started hitting the community level. There's some debate about this. But the idea is that we can apply novel data sources to try to uncover what's happening in a population. And clearly there's an opportunity to bring in analysis, automated analysis of satellite data, search query data in combination. The only downside, of course, is by putting out hypotheses and data, there's a huge downside, especially in this political climate. And I'm not going to take a political side here, but I would just say that nobody who is listening here would ever want a situation where the former president tweets about your research or a misunderstanding of your research, because that is when the bots unleash on you and claims about your intentions get brought up. And that was probably one of the darkest times of the pandemic, having dealt with misinformation and misinterpretation of our reasons for having done this research. And anyways, I'll leave it at that. But clearly it's just an example of scientists trying to put out data, make information available without any agenda, but clearly in the COVID times, you can't just do this without being thought of having some sort of agenda. Okay, we'll put that aside for now. But the point is that a lot of our work focused on trying to identify the events that were taking place early on, but more importantly, start to look at how cases were evolving across China, but also across the globe. And we started pointing our automated systems to actually track COVID over time. But the idea of monitoring news and social media to be a really important data stream as the pandemic evolved was clearly not there anymore because we needed much more data in order to fully understand what was taking place. And I apologize if I cough, dealing with a long COVID symptom myself. But what happened over the course of months after the first cases were identified is that an incredible amount of innovation took place in terms of tracking cases. And there was some incredible work done by Johns Hopkins University, the COVID tracking project, Our World in Data, which many I'm sure went to daily to see what was taking place. Incredible amount of effort to collect very messy data, organize it, and make it visually available. This is well beyond anything that public health agencies have been able to do. Our view was that there was a missing component of data that was needed at the time. And while many of those systems were focused on aggregate data, we also needed de-identified case information, because in order to fully understand what was taking place, you needed to understand the demographic characteristics, the risk factors, the location of cases, in order to fully develop models and forecast risk and understand the impact of interventions. And this is when we started focusing not on aggregate data or clinical data, but de-identified case data, line list information. And so in fact, we built a volunteer network and run by my colleague Moritz Kramer and Sam Scarpino. We developed a collaborative effort to actually codify every single case that we could identify on COVID, and did this manually. It was essentially a Google spreadsheet that was run by our group for many months. Eventually, we got funding from Google and Rockefeller that helped us automate this approach of building essentially the largest repository of publicly available data. And in the data set currently has over 100 million cases from over 100 countries with over 60 fields of metadata on cases. And that, from that perspective, was able to fully understand what was taking place in the population in terms of the demographic features, and making that data available in an open way to public health, to researchers, to policymakers, to feed into various models. And so ultimately, Global.health was born. And essentially the idea was how to build the largest repository of open public health data that could support various modeling efforts. With the funding that we got, we turned a volunteer manual effort into essentially an automated effort of data parsing, data cleaning, tagging, verification, metadata layering, and then of course having some curators on top of that. But essentially the idea was, how do you automate the approach of taking all this public data, whether it's Ministry of Health or other data sources, and taking, and very similar to how we did it for Health Map, but now taking a very detailed case information approach to actually building this raw data set. We've made this information available at Global.health. Anybody can take a look, download the entire data set, and see various visualizations, and basically explore the data we've collected. Clearly, this is very different than some of the other tools that you've seen that are much more focused on aggregate epidemiologic measures of cases, hospitalizations, and deaths. This is much more focused on raw case information so that people can use this for their research purposes. And of course, there's been a number of research papers that have come out from this. This is one example of using that data to understand the impact of lockdowns early on in China. Combining our case data with mobility data from Baidu, we could essentially build transmission models that allowed us to fully understand the impact of interventions in the population, including lockdowns. And of course, as we expect, lockdowns had an impact on reducing transmission in the community. We're building a lot of work in terms of data integrations and building a whole governance effort around this project as well. I did just want to take a quick detour on monkeypox because because a lot of the criticism, or at least the concern about some of these tools that we're developing, are that they're hard-coded for COVID, but will they actually be able to fully would be redeployed for other events. And of course, monkeypox is an important event, clearly important public health event, but also a real sort of important example of whether our technologies could be redeployed for another public health event. This is our Global.health GitHub that we put up pretty much immediately as the first cases were being identified. And in fact, Global.health now is the sort of the database of record for the globe in terms of individual cases that have emerged over the last month. And in fact, we've now worked with our World in Data to make that data more easily accessible by the general public. That data is all available, and we actually put out risk reports and understand the importance of travel history of cases, obviously how these cases skew much more male, and then combining that information with genomic information. So quick monkeypox detour, mostly all COVID, but important to note that we can sort of redeploy these technologies to other important emerging infectious diseases. Okay, so the next example that I'll mention is sort of the crowdsourcing efforts that we took place. So of course, there was data mining efforts to build some of those high-level information streams, but especially at the beginning of the pandemic where testing was not as available, we started turning to this concept of putting the public back in public health. We worked with Amazon, Apple, and Google to essentially build a crowdsourcing platform at the beginning of the pandemic that ultimately allowed us to collect very important information about cases in populations. And so we have had over 6 million people report their symptoms, their health behaviors, and essentially allow us to essentially have a syndromic surveillance platform of how COVID was spreading in a population. And what's important about these kinds of tools, these syndromic surveillance crowdsourcing tools, is they capture illness that does not involve interaction with healthcare systems. And for the most part, when people have had COVID, especially at the beginning, they were not having any interaction with health systems. So there was a missing sort of iceberg below the water of people that were infected, but never actually, their data was never actually collected. And so, for us, we were able to then start very quickly identifying rates of cases in populations, looking at the particular density of cases as the pandemic was evolving and seeing where the concentration of cases were taking place. Initially, we saw it in younger age groups, and then it eventually shifted to older age groups. And then we could also see sort of the patterns of spread as we started defining different case definitions for COVID. What ultimately happened was we built a much larger partnership with the company Momentive. They're formerly called SurveyMonkey. Many people know SurveyMonkey as a tool that you can create surveys. Well, they create actually an additional survey on top of the usual SurveyMonkey, an optional survey. And it's a cross-sectional survey where people can ask questions about symptoms, but also a wide range of behavioral questions. And we're getting about 50,000 responses per week. And that data set in itself became incredibly valuable for us to fully understand various behaviors that were taking place in the population. Like, for instance, what were people going to do as part of a holiday, post, in the middle of the pandemic in 2020, were people going to travel for the American holiday Thanksgiving, super important for most families. And in fact, a third of Americans were planning to actually travel and spend time with people outside their household. And this was in the beginnings of a really important surge that ultimately fueled more cases in the population. Probably one of the biggest and most controversial topics throughout the pandemic is mask wearing. And actually, I would say mask wearing is even more controversial, at least here in the US, compared to vaccination, which has always struck me as really confusing. We actually were able to collect hundreds of thousands of responses about people's mask wearing behavior and assign that geographically across the country. And what that allowed us to do was look at whether transmission would change as a result of people's mask wearing behavior. And what we found is the effective reproductive number, so the transmissibility of COVID in populations, communities where there was a lot of mask wearing, was much lower. So in a place where people adopted masks, you could drive down transmission. And somehow there's still a ton of controversy around this particular topic. But what we found is empirically, if you wear a mask, there's lower transmission. And in fact, if you combine social distancing measures with mask wearing behavior, you can see that, of course, in communities that there's more social distancing, more mask wearing, clearly you're going to be able to drive down transmission. I would say this probably gets the award for the most obvious finding ever. But again, given the amount of resentment that people had towards masking and the distrust in how masks could effectively drive down transmission, these kinds of studies were pretty critical to show their value. And it's not, these surveys are not just about understanding mask wearing. They're also important in terms of understanding risk in the population. Now, of course, we've moved to from the beginning of the pandemic, we had a situation where there was no testing. Then we moved into a place where there's a lot of testing. And now we've moved into a place where there's a lot of at-home testing, and that at-home testing never ends up in public health databases. People test at home and they never report that information. So the idea here was to try to understand whether, if you started taking our survey data, which identifies people that are using at-home tests, essentially apply a weighting function, and then you could basically correct for the percentage of home test users that go on for PCR confirmation or take a rapid test in a clinical setting, but many people don't. And of course, here in New England, locally where I'm in Boston, in the BA2 wave, substantially more cases that in the population that were just going unnoticed. So essentially a hidden wave that was going unnoticed as a result of at-home rapid test use. This effort, of course, was actually expanded out globally. We worked with Facebook to do symptom surveys in a similar way. And we could apply the same principles as we did for outbreaks near me in the US to actually a global system. And in fact, what we were able to do is validate the fact that by collecting data on symptoms, just through surveying people on Facebook, we could actually validate national trends in official data, but creates opportunities for not only nowcasting, but forecasting, especially in a world where testing is going down. So again, these systems can start to fill in important blanks. We're in fact doing some similar work with Google. They have an effort called Global.health studies, where we're actually recruiting people into a system, collecting data about influenza and COVID-like illness, and to better understand the relationship between illness and mobility. So being able to track these viruses in populations and identify specific behaviors that increase or decrease risk of developing COVID or flu. What's amazing now is, of course, with mobile devices and recruitment into clinical trials, we have this ability at the individual level to understand individual level choices and how those may result in increased or decreased risk. There's a lot more work that, I know I'm going to start to run out of time at some point soon, but there's a lot of work in wearables and connected devices in improving our ability not only to support decision making at the individual level, but also collecting data at a large scale. This is our tool called Thermia, which actually is a decision support tool for individuals to figure out if they have a temperature and the symptoms, what should they do or what should they do for their child. We have been working with various companies to integrate those decision support tools directly into connected thermometers, and the ability, of course, as an individual, not only just to take a temperature, but also take a survey and then improve the decisions at the individual level. But then when you start to look at the broad range of these devices and how many are being used, there's one-off temperature collection tools, there's continuous collection. But ultimately, we actually had these technologies deployed in 2019. And so at a global scale, we were able to understand people's reporting of temperatures through these connected devices. And we actually had this running in China at the time. And so we could actually see signals of reports of fevers and illness in the population ahead of official case reporting of COVID in a population. So this is more just an example of the fact that if we tie in some of these connected devices, decision support tools, they can provide a really incredible syndromic surveillance efforts. I'll just mention one other platform that we launched as a part, well before COVID, But a lot of my work is about, as mentioned, crowdsourcing at the sort of community level. There's also crowdsourcing at the expert level. We actually built a platform called EpiCore, which essentially recruits experts, epidemiologists, medical experts in infectious disease into a platform where essentially they can report and verify important events. So if you think about an event like COVID, you could essentially, this is essentially a bat phone for epidemiologists, where you circle an event, you can actually request response by people that happen to be near where you've seen a report of a particular public health crisis, and then you can get responses back and verification about that event. And so what we're trying to do is apply some of the same learnings of crowdsourcing and getting sort of the informal networks of, but in this case, experts to help us provide better context to public health events that we might be seeing in the population. There's a lot more work that we could talk about here. Vaccine confidence is one example where we can still use some of these crowdsourced surveys to get detailed information about people's reasons for, say, refusing to get the COVID vaccine, concerns about side effects, testing, lack of trust in the government. And we can start to look at changes in some of those feelings over time. As more time goes on, more people become confident that they might take the vaccine, but also important changes, right? So in the US, we had a pause of the J&J vaccine as a result of some concerns of adverse events. Ultimately, the pause was lifted and the J&J vaccine deemed to be reasonably safe, but the impact on vaccine confidence never recovered as a result of that pause. And we saw our two other vaccines, Moderna and Pfizer, sustain confidence. So it's very important to be able to look at these types of changes in confidence over time, and as they may reflect important insights into how you might want to communicate to the public and change course in terms of what interventions you might focus on. And of course, these various topics change over time, and it's important to be able to understand which are the leading reasons why people are deciding not to get vaccinated, and also the external factors that are driving some of those decisions. Clearly, and this was another paper that we published in the New England Journal of Medicine. This was a topic where we looked at sort of the lack of sort of fully understanding on the part of the population in terms of timing of protection. There's still lack of clarity of whether people are protected after the first dose, the second dose, and how much time after the second dose. And so understanding the reasons why, where the confusion exists and where there's misinformation about, for instance, whether people should continue to wear masks even if they're vaccinated, super important for tailoring communication and public health messaging. And of course, if you start to look at the pediatric vaccines and look at age ranges as you go down in the population, there's more and more hesitancy. We just had, of course, authorization for vaccines for kids under 5 here in the US. A lot more concern as you go down into the younger age groups. And that's something that we have to work on to understand how to educate the population about how these vaccines are still incredibly safe, even for our youngest kids. I'll just mention the one last platform that we launched as part of the COVID response. We've been running actually for close to 10 years now, a tool called Vaccine Finder. It was actually originated by Google as part of the 2009 H1N1 and flu pandemic. We built a tool essentially allowed people to go on and figure out where to get access to flu shots, and then eventually built it for a range of vaccines. We redeployed this platform, built a whole infrastructure for collecting supply and inventory information, basically from every vaccination site across the country, and built a public site called vaccines.gov, which is now has been used by over 100 million people in the US to figure out how to get vaccines. And I guess this is maybe my redemption a little bit, because in this particular case, the president used vaccines.gov as sort of the sort of key response tool to help people figure out how to get vaccinated. And so a little bit of a 180 degree from the previous presidency. But ultimately, what we were able to do is build all these really phenomenal collaborations, because we had essentially the the validated data set on vaccination locations, we could then work with companies like Google and there are ways to help people identify where to get vaccination sites in the community. Also similarly with Apple Maps, you could ask Amazon Alexa where to get a COVID vaccine and it would pull from our data. And then we even did some very odd partnerships, like a partnership with Tinder, which was probably our oddest one, and Bumble, where people could swipe and identify vaccination sites. And so some odd partnerships, but some really exciting ways to get the word out about the data set that we were pulling together. But I think an important insight that we gleaned from being able to have all this access to vaccination site information was also where vaccine wasn't. And we started building maps of vaccination deserts in the country and identifying many parts of the country, 30 million people that are not within close proximity of a vaccination desert. And as you can imagine, those places happen to be also low income populations, minority populations, low underinsured populations. So the same people that were dealt with the hardest impact of this pandemic were also ones that were essentially, in a position to not be able to access vaccines either. And so ultimately, we started trying to understand this because it's not just about access, but it's also about hesitancy. And what we found is that proximity to vaccination site and hesitancy are linked. If you are more interested in the vaccine, you're more likely to drive further to get that vaccine. But if you're hesitant, you're less likely to drive further. So if you think about someone who's on the fence about getting a vaccination, if it's hard for them to get, they're probably not going to do it. And so there's this challenge of trying to make sure that vaccines are as convenient as possible, because that might tip someone over the scale and ultimately get them vaccinated. And in fact, we built a whole planner tool for state public health sites that takes the survey data and matches it with vaccination site information to fully understand how to optimize vaccination site information based on all this metadata. So important to understand both the geography and decision and the landscape of vaccination sites, but also understand sort of the intentions of people in those particular places as well. So anyways, just to start to wrap up here, we've learned a lot of lessons clearly, and I know I've gone through this quite fast, but the view is that there's opportunities to leverage existing data, right? Public health does not need to focus on collecting primary data. There's massive amounts of information that exists online or through partnerships, and there's a lot of commercial companies that are willing to provide data to support efforts, and we've been the beneficiaries of that. There's also an incredible drive now to make data open, and I would say pre-pandemic that really wasn't the case. Now I think there's essentially not a requirement, but an expectation that anyone who's developing data for public health purposes make that information open. And I think we're going to see this become more and more the mainstream view, as well as some of the public-private partnerships that were created as part of the pandemic. Hopefully, those will continue because clearly COVID isn't our last pandemic. And then in closing, the view is that there is an opportunity to build this disease weather center, and some of the examples I brought up today are in each of these buckets, but clearly there's so much work to be done. So not sure who's listening out there, but it's really such an open space right now, whether you're focused on opportunities for the collection and ingestion, curation, stewardship of data, the aggregation, hosting of that information. The amount of data that we have is far greater than our team's ability to analyze it. So there's massive opportunity in terms of the amount of data that was collected throughout the pandemic for analysis, obviously data visualization and reporting. And then, of course, the most important is figuring out how to make sure that these efforts are used by the people who can do something about them. And so that, of course, represents still a whole other vertical where there's a lot of green space, where hopefully a lot of people will be piling into public health, because clearly public health has not had the advantage that other industries have had in terms of the computational expertise. But hopefully that is changing right now. So with that, I'll thank you so much for your time, and I look forward to any questions.
Thank you very much, John. That was really amazing and very clear, very impressive as well on just the sheer amount of data that you've been using. So we have more than 60 people online and an unknown number who's following us on the live stream on YouTube and Twitter. So please consider logging into the neural network so you can interact with us. And please let us know your questions. We have 15 minutes to discuss. And in the meantime, I'll start with a question. So to put it all in perspective, I would like to start by asking, WHO realized that there's a need to integrate data to have sort of, teams working on continuous modeling and retrieving data. Can you tell us a little bit about how, and what you can tell us about the WHO Hub for Pandemic and Epidemic Intelligence and your collaborations?
Yeah, so it's just getting off the ground. So there's still a lot of work that they have in front of them, but the work that we have with them is to figure out how to bring some of these open data tools into sort of the WHO space. And generally speaking, the way public health, and I mentioned public health generally operates, which is there's, ministries of health reporting data into the WHO. There's not necessarily a lot of sort of public display of this information or open data sets. So clearly what we're doing with Global.health has an opportunity to help facilitate, create essentially a public arm and make some of these data sets that are, of course, not individually identifiable, more available. The same group that runs the Pandemic Hub has been developing epidemic intelligence systems for many years, the EIOS platform. And we've been actually feeding data into those platforms for many years. And they're the ones that have really been leading a charge in terms of integrating data from disparate information sources, developing operational assessment, situational awareness. And I think now the idea is, how do you take some of the learnings from that effort and build upon them? And I think the hub, what's really exciting is that they are not inward facing. They're really trying to make sure that they're working with sort of best in class, researchers and looking outwards to partnerships. And that's, I wouldn't say necessarily the way that WHO has operated, but I think there's a recognition that if they're going to build sort of platforms, whether they're, the earlier learning platforms, whether the surveillance platform, response platforms, it's going to require, academic and industry collaborations. And that's really, we're happy to be with them at the starting point as they're evolving their efforts.
Yeah, it's very exciting times, but we all know that massive projects like this take years to kick off. I was wondering, as you spoke, the data you've used for your analyses is mostly came, from data sources, from Facebook, Twitter, Google searches. How about places where they don't use these services? And also places where they don't use any of these services at all, and maybe even lower amounts of smartphone use and internet use.
Yeah, that has always been a challenge. Some of these tools are only as good as the data availability in those places, and there are massive gaps in terms of use of these tools, but also mobile phone use, those kind of things. There are ways in which we can fill in those gaps with, not necessarily Facebook, but crowdsourcing tools, other types of technologies. But even in places that are considered under resource settings, we've been able to build tools to capture information. For instance, Ebola outbreaks that happened several years ago, there was a view that there would not be enough data to understand and build situational awareness. But through the mining, not only of local media and social media, but also relying on experts on the ground, we were able to develop some pretty rich situational awareness of what was taking place. So I would say most parts of the globe, there's some constellation of data sources that we can pull from. We have to recognize that not every single data source has perfect global coverage. But I think that generally speaking, well, we've moved a little bit away from the mining of sort of social media and focus a lot more on proactive survey-based tools that either leverage social media like Facebook or SurveyMonkey, or can be done via text message, smartphone, not smartphone-based tools with questions that can be answered just via text message. And sometimes you have to fund some of that work, or you have to create incentives, but there are plenty of ways to be able to capture data. I would say in most parts of the globe at this point.
Yeah,
most everywhere. Yeah.
John, can you maybe comment on your plans and progress on incorporating your analyses and the data you've been using with more traditional data sources, hospital data, electronic health record data, pathogen genome data?
Yep. Yeah, I mean, look, I think that as part of Global.health, as an example, we're integrating with genomic information. There's a whole field effort of trying to bring some of these epidemiological data sets alongside more of the traditional epi collection. Our view, of course, is that it's the combination of data sources that provides the best view. Actually, we've been doing this well before COVID. There's really good work suggesting that if you integrate some of the non-traditional data sets, whether it's the crowdsource or Twitter data sets, alongside more traditional data sets like clinician visits or hospitalization data, it's the combination of signals that will provide the most robust view of what's taking place in a population. So, it's absolutely true that if we can pull together as many of these sources together, you're going to get the best possible picture. Each data source has its various attributes and accuracy and delays. But if you're able to pull that information together, like we've definitely shown this for influenza and then COVID, that it's the combination of sources that provide the most rich signal.
Yeah. Okay. And then from the audience, we have Min Trin, who's wondering, what is state of the art of integrating these new data into traditional epidemiological models?
I don't know. I mean, I sort of answered that. I mean, there was, I presented a little bit of that during the presentation where, we're able to use some of the insights that we're gleaning from the epidemic curves that we're building to make estimates of transmissibility. We've done this for measles. We've done this from other sources as well. So the question is, can you, build an epidemic curve from the data that we glean from the crowdsourcing data, from the social media data? And the answer is yes. It's imperfect, but they can be used as surrogates, especially in the beginning of a pandemic where you don't have the best possible case data, that you can use those as sort of generally a substitute at the beginning. And I think that's, where things stand now. Again, these are not substitutes, but they're good initial data sources that you have access to immediately that can help serve epidemiologists as they're trying to characterize an infectious disease event.
Okay. And have you used your data also to make predictions, to sort of create risk reports and be like, based on Google searches, we expect next week?
We've done this, for a number of years. I mean, I think that with COVID, I think you can build models that, forecast a few weeks out. And our focus has been trying to collect as much useful data as possible and hand that over to some of the forecasters. I think you can get reasonably good forecasts 2, 3, 4 weeks out. Beyond that, I think these models so far have been more challenged. And I think even some of the best forecasters would suggest that it's really hard to go beyond some of that. But even being able to have the data, the nowcast data, is super valuable. And sometimes that's even better than traditional data, which is usually can be lagged by 1 to 2 weeks.
Yeah. Because of the traditional reporting.
Yeah.
So we have Edmund Ng asking, so he's first applauding you on collecting this massive amount of data for surveillance, but he's asking, what are you doing in terms of risk mitigation in case these types of data fall into the hands of those who shouldn't be seeing them, e.g. authoritarian regimes? Yeah, no, it's a very good question. I mean,
obviously we are trying, different data collection tools have different levels of sort of detail. The majority of our crowdsourced information collects very minimal individual information. I mean, we're collecting data, about, very basic symptoms and, we're collecting age and gender, but, very limited data that I don't think would provide any type of, any type of downfall. I mean, clearly a lot of this data is out there publicly. So, what we presented at Global.health is actually already public data. This is not information that is already that is being crowdsourced. I mean, some of the crowdsourced data on Facebook, there's a lot of thoughtful effort that has gone into privacy protection, data storage. We think through all of those clearly, and we go through very detailed legal and compliance as we collect these data and think about GDPR and other legal constructs as we collect this kind of information. I would say that, there's a lot more risk in some of the other data that people provide into these social networks comparatively to what we're collecting right now. But yeah, I think that, it's important. So I appreciate the question. It's something that is top of mind, almost, ahead of any of the research questions, is how we ensure data protection as we're collecting these kind of data and making sure that they're not, as you said, manipulated or utilized for political agendas.
Okay, thank you. That was a good answer. We have Rongbo, who is again applauding you for this amazing talk, and he's wondering, how would the epidemiologists of the future avoid the misuse of academic and scientific published work being misused by for politicians for their own?
Yeah, that's a good question, and I wish I had a good answer for you. I wish that too, truly, because it was dealing with that particular situation where we made data available, and then our study was misinterpreted and used for political agenda was really very, very tough. And I think, that was especially the climate back in 2020. It's less so now, but it's still concerning. And I've seen a lot of my colleagues take huge amounts of hits by being more public and trying to put out various data sets, in whatever direction. So it is very tough. And I don't know, how to prevent this in the future. Clearly, it's something that, it's not something as an academic go into research, and that's not something anybody's teaching you or explaining as you think about how you communicate your research. It is a whole new world now with Twitter and other ways of communicating data, that you're engaging with communities that you never were. And it, used to be just through your peer-reviewed scientific publication and maybe a press release and a news media story. Now it's a totally different landscape. And so, you'd hope that government agencies were doing more to protect scientists, but of course, some of those same government agencies are doing the exact opposite. So, I hope hopefully someone has an answer out there for this. That's a great question.
Great. So in my postdoc work on tuberculosis transmission, I've collaborated with several public health departments, and I wonder, and I don't think any of them would be using data that you've presented. How far do you think public health agencies are away from actually using tools as you have and data sources as you have for understanding epidemics?
It's a really mixed bag. I think they've come a long way in the pandemic. WHO has an incredible set of people that are really leaning into this. At CDC, which is our very close collaborator, there are many groups that are absolutely thinking about this, and others that are maybe more cautious about stepping in. But we've seen investments in novel data sources like wastewater surveillance and other sources of data, which you would never have imagined 5 years ago CDC investment in. So there has been a real change. I think part of the issues in public health and epidemiology, there's often a reticence to go into some of these data sets, because if it's not perfect data and it's got biases, then it's not worth utilizing. And I think that's the wrong approach. I think is if you understand the biases, recognize the limitations of data, there's still a huge amount of value. And I think, but for public health and even academics, they just have basically said, well, it's not a clinical trial, so you can't, there's nothing to interpret here. And that's changed. So I think slowly but surely, and especially the last couple of years, we've seen a real tide shift in terms of the adoption of these data sets and methods.
Yeah. Okay, we're almost at the hour, and I'd like to, I'll ask my ITU colleague Julian to monitor if there's any remaining questions. But if not, I wanted to ask you, John, we might have a couple of students in the audience. Can you maybe close by painting out your vision of the epidemiologist of the 21st century and the field of epidemiology in the 21st century?
Yeah, well, listen, I think that there's the classic epidemiologists that focus on very specific data and very specific methods. And there's an entire new field that's emerging that is utilizing these large data sets, that utilizes computer science and large data processing. There are not enough people that are taking some of these sort of modern methods and bringing them into public health. And so I think there's so much opportunity. Yes, there's an old guard of public health that you may have to sort of work against, but the new epidemiologist, thinks about the broad range of data sets, that understands that integration of data is key, understands that it's not just about academic data collection, it's about private partnerships and utilizing, the companies that have the most data on earth are not government agencies. And so if you're going to work in public health, thinking about the broad range of unconventional data sets, which is, the tech companies, the credit card companies, the insurers, there's lots of different really unique partnerships. And through those partnerships, you can ask some of the most unique questions. So, there's so much opportunity if you sort of break out of the existing mold of what an epidemiologist is supposed to be.
Yeah, that sounds really exciting. I wish I could go back to college. All right. So, John, thank you very much for joining us. That was really excellent. Such a timely topic and really impressive and inspirational.
Thank you.
I'd also like to thank colleagues at ITU for, putting this up, and colleagues at AI for Good as well. I'd like to point the audience to the upcoming webinars. We have 2 more before the summer break in July. On July 6th, we have Stevie Chancellor, and on July 7th, we have Marcy Gasemi. She's at MIT and has done incredible work on bias in AI models. So I highly recommend you sign up. And so, yes, thank you again, John. It was an honor, and hope to see you sometime in life.
Yes, absolutely. Look forward to that.
Thanks a lot.
Thank you. Okay. Bye.
Thank you for participating in today's AI for Good session. We hope you've learned something new, innovative, and engaging in today's event. We now encourage you to continue the conversation on the live video wall in the neural network. Here you can ask questions, like and comment, share links, complete the satisfaction survey, connect with interesting profiles, or speak one-on-one using the chat and video function. After the 30-minute networking session, we invite you to explore the lobby, try the smart matching quiz, visit the virtual exhibits and poster boards, and build your personalized AI for Good program. It was a pleasure learning with you today. See you at the next AI for Good.